with today's focus on opioids. And today we have an very experienced and eminent faculty joining us to walk us through the session. So let me introduce to him with personal privilege. I am introducing Dr. Sunil Kumar, MM, who happens to be, just a moment, who happens to be the Additional Director of Trivandrum Institute of Palliative Sciences, the WHO Collaborating Center for Training and Policy on Access to Pain Relief at Trivandrum. Dr. Sunil Kumar has a diploma in palliative medicine from India and Cardiff and master's in palliative medicine from Cardiff. Am I audible?
Ma'am, your screen is not visible.
Is it visible now?
Yeah.
Thank you, Anu. Thank you. So I believe that I have not left out anything. So coming back, Dr. Sunil Kumar is having 15 years of extensive experience in palliative medicine, and presently the clinical services, academics and research wing of Pallium India are being overseen by Dr. Sunil Kumar. So sir, without much delay, I hand over it to you to enlighten us on management of pain using the opioids. Over to you, sir.
Thank you, Priya. I hope I am audible.
Yes, sir.
Okay. So I will share my presentation. Okay. So you already covered two sessions on pain management. One is on general aspects of pain. Sorry, including pathophysiology and types of pain. And then you also had another session on WHO step ladder, steps 1 and 2. Now we will move on to third step of WHO analysis ladder. Okay. So the only difference from second step is that in the third step of WHO analgesic ladder, we have opioids for moderate to severe pain, or many people call it as strong opioids. Okay, so we will see what are the opioids available in India, because there are many opioids you will come across when you read which is not available in India. So we will concentrate only those opioids which are available in India. Then what is the mechanism of action? And we will have many doubts regarding the use of opioids, when to use, how to step up. So these are common doubts everybody has. So we will go through that. Then another main issue for professionals is that opioids have so many problems, adverse effects. So how are we going to use it? So we will talk about the adverse effects of opioids. Then it is also important to understand the price of different opioids, because if you are going to prescribe some opioids which are costly, the poor person may not take it, because they do not have money to buy it. And this is one of the commonest reason for unsatisfactory symptom control. So it is also our duty to understand the pharmacoeconomics, so we can prescribe in a better way. Okay. So this is what we were talking about, WHO three-step analgesic ladder. And in the third step, we have opioids for moderate to severe pain, along with non-opioid plus or minus adjunct. So you can see a person here. So by seeing this photo, what do you think? Suppose this patient comes to you. What would be your main concern on seeing this patient? I would like you to be interactive so that we can move forward. So what is the what is your concern if you see a patient like this? Anybody can unmute and speak.
Patient looks cachectic. Patient definitely looks in pain. And as the definition of health goes, patient doesn't fit into it.
Thank you, Dr. Tino. Anybody else? What is your primary concern? You can unmute and speak. There is no wrong thing. Whatever you say is only right.
He's obviously very distressed and suffering with pain or something else.
Okay. Thank you. That was Meera. Okay. And suppose, yeah, this patient, you can actually our primary concern when you see a patient like this, it should be his facial expression, isn't it? That's what it is. It is very evident. What is very evident in this photo is his facial expression. He is in distress. He is in severe pain. Okay. So if you see a patient like this, how are you going to manage his pain? This very severe pain. How will you manage?
First, we will definitely assess the severity. We would
Yes.
try to find the underlying cause.
Mm.
And then we will start with the, as we have the analgesic ladder, we'll start with step 1 or 2 or 3, ladder 1 or 2 or 3, sorry, and we'll see how the patient responds, and accordingly we'll add or subtract the medicines.
Thank you, Dr. Tinore. So, anybody has any different idea than what Tinu told? So, which step of WHO analysis ladder would you use in this patient? Yeah, I can see Dr. Karen says third step. Okay, you can also use the CAT option. Okay, this patient has a very severe pain. So, which is the WHO, which is the step of WHO analgesic ladder that is used to treat severe pain? That is step 3. So, there is no doubt that if the patient is in severe pain, we have to go straight to the step 3. We need not start the patient on step 1 and then go to step 2 and then go to step 3. It is not necessary. You can directly start the patient on step 3. Okay. So now tell me, what are the opioids available in India in the third step of WHO analgesic ladder? Which all opioids are available to us? Please unmute and speak. If you don't speak, class will not go forward. So, whatever you know, that's all what we need.
Yeah, sir, tramadol.
Karthik.
Yeah, tramadol, fentanyl, and morphine.
Yeah, tramadol is not a step 3 opioid. It is an opioid that comes in step 2, isn't it? That is an opioid used to treat mild to moderate pain. So it is a weak opioid that comes in second step of WHO analysis ladder. But morphine and fentanyl, these are two opioids which comes in the third step of WHO analysis ladder. But there is one more opioid which is available in India, that is methadone. So morphine, methadone, fentanyl, these are the 3 opioids available in India for treating severe pain. So out of this, which opioid are you going to treat the pain of this patient?
Morphine.
Morphine. Okay, yeah. So morphine is the gold standard for treating severe pain around the world. Okay. So this patient, okay. So this is the story of this patient. He's a 56-year-old man, carcinoma of the larynx, and he presented with severe pain, and he scores 10 by 10. That is worst imaginable pain. And he says it is a sharp pain. There is no radiation. And this was there for the last 2 weeks. And because of this pain, he is unable to sleep. So pain is so severe that he is unable to sleep. So after some time, maybe after an hour, patient is smiling at us. So what is the magic behind it? How he can smile like this after an hour?
Tracheostomy intervention.
Tracheostomy?
Intervention. He can breathe very better, I feel, after this
Pain.
tracheostomy.
Pain relief. He had the tracheostomy in the first picture also. You can't see it.
Yeah, in the first picture also there is tracheostomy, but you are unable to see. But you can see the part of the note here, the white on the left side of the neck. So this is because of
Pain
morphine.
relief.
Okay. So as you told, we tried with injectable morphine. So if a patient has very severe pain, you can actually give injectable morphine in titrated manner to find out the. There are 2 things you can find out. One is whether the pain is opioid responsive, and you can also find out the dose of opioid required for pain relief. Okay, so this is known as intravenous morphine titration. So how many of you have injectable opioids in your institution? Just give your answer in the chat box. Yes or no? Yeah. I can see one response. No, no. Yeah. Only. Okay. I can see some people have morphine, injectable morphine, and some people doesn't have injectable morphine. So we will see how to give morphine in a titrated fashion by intravenous route. So you have to give injection morphine 1.5 milligrams at 10 minutes interval. So you will give injection morphine 1.5 milligrams now and wait for another 10 minutes before giving another 1.5. Okay. So what is the immediate side effect that you are expecting with this 1.5 milligram of injectable morphine? Immediate side effect. Dr. Harsha says sedation. Madhumita says vomiting. Any more answers?
Respiratory depression.
Right. Respiratory depression. Yeah. Daisy, Sri Ramas, and Karthik. Yeah, there are many people talking about respiratory depression. Okay. we will talk about that in the later part of our speak. But the immediate side effect that you need to expect with this 1.5 milligram of morphine is nausea and vomiting. Okay, so you have to give an antiemetic to prevent nausea and vomiting. So usually we give injection metoclopramide 10 milligram IV before starting injection intravenous morphine titration. And how long would you continue to give injectable morphine? So either the patient should have satisfactory pain relief or the patient should develop drowsiness, whichever be the first. Okay, either satisfactory pain relief or sleepiness, whichever be the first. So before giving a morphine trial, you can make a chart like this. So which includes time, pulse rate, respiratory rate, blood pressure, pain score, is the patient drowsy or not? What is the dose of injection morphine you have given? So you can see here, suppose this patient came at 10 a.m. You recorded the vitals and the pain score is 10. Patient is not drowsy, then you will give injection morphine 1.5. Then you will wait for another 10 minutes. So at 10, you will again look for the vitals. You will ask the patient, how is your pain now? Can you tell me what is the pain score? It is 7 now. You see the patient that he is not drowsy. So you will give another 1.5. And you can see after 3 doses at 10:30 a.m., this patient pain score came down to 1. And patient is also not drowsy. So this patient has satisfactory pain relief. So this is an indication to stop morphine trial because he has good pain relief. Okay, so this patient totally he received 4.5 milligram of IV morphine. So is this intravenous morphine titration an inpatient procedure or outpatient procedure?
Inpatient procedures.
Inpatient procedure. Okay, anybody else? Yeah, I can see Puneet says IP. Madhumita, everybody says inpatient procedure. But believe me, it is not an inpatient procedure. We can safely do it as an outpatient procedure. So we usually do 1 or 2 intravenous morphine titration every day for patients with severe pain. So this patient received 4.5 milligram of IV morphine. So patient immediately after pain relief, he wanted to go home. He says, doctor, I want to go home. So what would you do? You have to convert intravenous morphine to oral tablet, isn't it? So oral morphine. So with 4.5 milligram, he had very good pain relief. So how will you convert, or what would be the dose of oral morphine that you are going to give this patient? Any idea? 1:3 ratio. Niranjan says 1:3. Okay.
15 mg.
15 mg. Yeah, Karthik. Yeah, Niranjan and Karthik. You are right in a way, but there is some catch there. So both of you know that whenever we convert intravenous morphine to oral morphine, the intravenous morphine need to be multiplied by 3 for getting the oral morphine. That is, intravenous morphine is 3 times more potent than oral morphine. But this is not applicable here. It will be applicable for a patient who has stable concentration of morphine in the blood. Okay, for morphine to get the blood level stabilized, it will take about 24 hours. then only it will give constant pain relief. But here, there is the blood level is not at all stabilized because you have given only for 3 doses of morphine, and that also in 30 minutes. That means the blood level is not at all stabilized here. It has not reached a constant level. It will take 24 hours to reach the constant level. Okay. So even though the ratio that you have given is correct, but it is not applicable here because the blood level is not stabilized. Okay. So but in a patient who has taken intravenous morphine, suppose a patient is on intravenous morphine, 30 milligram of intravenous morphine for the past 24 hours. That means the blood level would have stabilized. So in that patient, you may convert it into 90 milligram of oral morphine, 90, by multiplying by 3. But here you have given only 3 doses of morphine. That means blood level is not stabilized. So, the recommendation is to convert it in a 1:1 ratio. What is the intravenous morphine you have given? You can directly convert it into the oral dose, 1:1. So 4.5 milligram means it is 4.5 milligram. So this is the reference. This is study done by Dr. Rajagopal and his colleagues in 2000. Intravenous morphine for emergency treatment of cancer pain, which is published in Palliative Medicine. And we follow this. And most of the patients will get good pain relief with this 1:1 conversion. Okay. Any doubts? So in this patient, we have given 4.5 milligram of morphine. So from a practical point of view, we can give only 5 milligram orally, isn't it? Because the available morphine tablet is 10 milligram. So you can make it half. So what is the duration of action of morphine?
4 hours.
4 hours.
Yeah, 4 hours. Okay, so 3 to 5 hours. So morphine should be given every 4 hours. So you can see here, this patient, we are giving morphine 5 milligram every 4 hours. But suppose the first dose is given at 6 a.m. Then the next dose at 10 a.m. Then 2 p.m., 6 p.m. And next dose would be at 10 p.m. But you know that most of the patients who is in pain, they will be sleeping in the morning hours usually. So you need not wake them up. Wake them up to take morphine. Let them sleep, and you give the first dose when they wake up. But the next dose is given at 10 a.m. And likewise, you need not wait till 10 p.m. to give the bedtime dose. You give whenever the patient wants to sleep. So you can see at bedtime, you are giving double dose. It is not single dose. Okay, this is to avoid 2 a.m. dose. So if you calculate 4 hourly, the bedtime dose means it is 10 p.m. Then after 4 hours, that will be in at 2 a.m. So in order to avoid the 2 a.m. dose, you can see it is at bedtime the double dose is given. So this is how morphine is administered in most of the countries. But in addition to this, you can also use or ask the patient to take SOS dose. SOS would be the same as the regular dose. So regular dose is 5 milligram. So SOS dose would be 5 milligram. Suppose a patient is taking 50 milligram of morphine 4 hourly. then SOS dose would be 50. Okay. And many of you may not have injectable morphine. So in such situation, you can give oral morphine trial. So if the patient is not taking any opioids, then start the patient on 5 milligram of oral morphine 4 hourly and SOS. But if the patient is taking weak opioids like tramadol, tapentadol, or anything else, then you can start the patient on 10 milligram of oral morphine. Dr. Nirali, do you have any doubts?
Yes, doctor. I have
Yeah,
a doubt
tell me.
from the previous slide. So,
Sorry.
as you mentioned that
Yeah.
bedtime, we can give double the dose of morphine,
Yeah,
which is around 10 p.m.
yeah,
But what if the patient also, definitely there's going to be a good 4 or 5 hours gap in between. So we can give the SOS dose after 4 hours. Or how do we give the SOS dose if the patient is feeling pain in between the doses?
okay. We will come to that. Okay. So oral morphine, if you have only oral morphine, start with 5 milligram in patients who is not taking any opioids. But if the patient is on weak opioids like tramadol, tapentadol, or codeine, stop that and then start the patient on 10 milligram of morphine 4 hourly and SOS. Okay. So please read this patient story. Somebody please read it for me.
Mr. X was started on 5 mg QID dose and SOS. He was relatively pain-free for 2 weeks. He needs 4 SOS dose of morphine per day for the last 4 days. What shall we do now? How frequently would you give SOS dose of oral morphine?
Thank you, Dr. Harsha. So the patient whom we saw, he was started on 5 milligram of 5 milligram of morphine 4 hourly after intravenous morphine titration. He was relatively okay, but then he needed to take 4 SOS dose of morphine per day for the last 4 days. So, do we need to do anything with morphine? And the second question, Dr. Nirali asked, how frequently would you give SOS dose of oral morphine? So, any idea? Anybody can speak?
Sir, I feel that we need to step up and increase the dose of the morphine which he is taking. Maybe the 5 mg morphine is not sufficient for him. So if we increase the dose to 10 mg for every 4 hourly, the SOS dose requirement may decrease.
Okay, thank you, Dr. Harsha. Yeah, anybody has any other opinion?
Sir, my step doctor, sir, optimal dose is
Your voice is
making
breaking.
patient.
Sriramu, your
Yes, sir,
voice is breaking.
Sir, I'm Dr. Chakravarti, sir.
Please, switch off your video.
I'm having network issues here, sir. Sorry, someone can continue. Someone please take over.
Okay, I can see some of the chat responses. Karthik says increase it to 10 milligram. Vishnupriya says since it's 4 days, those can be increased. Yes. Okay. So there is one more response. Niranjan, adjuvants can be considered if neuropathic pain is present. Okay, this patient's pain is all around the neck, which was sharp and continuous in nature. That means most probably it's somatic pain. Okay, not neuropathic pain. So opioids would be the better choice here. So he needed 4 SOS doses. What are we going to do for this patient? So as Dr. Harsha told, we can increase the dose of morphine. So when would you increase the dose of morphine? If the patient is taking 2 or more than SOS dose. 2 or more than 2 SOS dose. PRN means it is same as SOS dose. Then you can increase the dose of opioid by 30 to 50%. Sorry, this is not every 2 to 3 days. It is every 24 hours. Okay. So this patient is taking 4 SOS dose. That means you need to increase the dose of SOS morphine. Okay. So 30 to 50%. So 5 milligram, 30% would be 1.5 milligram, isn't it? But it is not practical to give 6.5, 5 plus 1.5, that's 6.5. It is not practical. So the next possible increase would be 50%. So 5 into 50 percentage means that is 2.5 milligram. So you can add the 2.5 milligram. That is 5 plus 2.5 milligram, 7.5 milligram. So 7.5 milligram every 4 hourly and SOS dose. But some people find it very difficult to break the tablet into 4 pieces. So even 10 milligram should be okay for this patient. But please remember that you can increase the dose of morphine 30 to 50%. Okay, every day. So this is what Dr. Nirali Patel asked. How frequently would you give SOS dose of oral morphine? And also explain why. Anybody?
As the patient requires, according to his requirement, whenever he tells pain, we should give him.
Yes, Dr. Premlata. But suppose the patient has taken a tablet of morphine 5 milligram at 10 a.m. Patient by 10:30 says, Doctor, I have severe pain. Please do something. So what would you do?
Check his vitals, and really we have to reassess him whether it is really this pain or any other pain, and then accordingly you have to decide.
Yeah, that's correct. Suppose it is because of physical pain itself. So after evaluation, you find that this is due to physical pain itself. So what would you do?
We have to give him the second
Okay.
dose.
Yeah, thank you. So before going into the answer, let's see the logic behind. This is the Papaver somniferum or poppy plant. Okay, and it is legally grown only in 3 states of India. That is UP, MP, and Rajasthan. Uttar Pradesh, Madhya Pradesh, and Rajasthan. So you can see these are like paddy fields. These are opium fields. Okay, and this seed-like thing is known as pod, POD pod. What do you think? From which part of this plant you will get morphine? It is available, or it is available from all the parts of the plant. Okay, morphine is present in all parts of the plant, but it is most abundant in pod, that is seed-like thing. And you can see farmers are making small cuts on the pod, and this is the sap coming out from the pod, and they will collect it, dry it in the sunlight, and then this will be transported to government opium and alkaloid factories, where they will make morphine powder out of it. Okay. So when you swallow morphine, what happens to morphine? It is absorbed from the upper small intestine, and the morphine is hydrophilic, that is, it is water soluble. And because of this water solubility, it has low onset of action, but has a longer duration of action also. And when we speak about oral routes, there are many medications which is administered sublingually or buccally or gingivially, but morphine should not be given sublingually because it is absorption is very low. So we don't know how long you need to keep the morphine under the tongue. So a morphine is not advisable to give sublingually or a buccal or through gingival routes. And another thing is that when you powder the morphine tablet for patients, for those patients who are unable to swallow, then make sure that it is sweetened with some fruit juice or sugar because it has a bitter taste. So this is what happens to morphine when you take orally. So it goes into the GI tract, absorbed into small blood vessels or small intestine. Then it goes to portal vein and then to liver where the metabolism takes place. So liver is the site where the metabolism takes place, or that is the major site of metabolism. And there are other minor sites like the intestine and kidney. But liver is the major site where metabolism takes place. And then metabolites are liberated into the systemic circulation. Okay, so you have to swallow the tablet. It will go into the small intestine, and from the small intestine, it is gradually absorbed into the blood vessels. Then goes to portal vein, and from portal vein to liver, where metabolism takes place, and then the metabolites are liberated into the systemic circulation. So this is something which you need to understand. 90% of morphine is converted into metabolites. Okay, but you can see 45 to 50% is converted into a metabolite known as M3G or morphine 3 glucuronide. In short form, it is M3G. And only 5 to 10% is converted into morphine 6 glucuronide or M6C. And out of and there are many other minor metabolites. But the M6C is the metabolite which will give you the pain relief. Okay, so or in other words, it is the active metabolite. M3G doesn't have much action in our body, but sometimes it may contribute to neurotoxicity. Okay, so M6C is the component which will give you the pain relief. So this was the question that we asked: how frequently would you give SOS dose of oral morphine? So you have to understand it has to go into the small intestine, from where it is gradually absorbed, then goes to liver, and then metabolites are liberated into systemic circulation. That is M6C. That is the main component which you are going to get pain relief. So this process will take some time. So the pain relief will start by about 30 minutes, but the peak of pain relief will be by 1 hour. Okay, so it is safe to administer morphine after 1 hour of the previous dose. So that's the answer for this question. So somebody please read this. So the same patient.
Mr. X pain was stabilized with 10 milligram or
Yeah, Dr. Abhurva, please continue.
Mr. X pain was stabilized with 10 mg of morphine 4 hourly, but he finds it difficult to take it every 4 hourly. He says he is willing to take it if you give less frequently. What will you do?
Yeah, what will you do? Anybody?
So we can increase the dosage.
Okay, but still you have to give it every 4 hours, isn't it?
Give extended
So
release.
rather,
Okay, I can see John Babu says give 20 milligram PID. Okay,
Extended release option is there.
yeah. So that's what you can do here. Extended release or sustained release or controlled release. Okay. So this patient is taking totally how many milligrams of morphine per day?
40 mg.
Is it 40?
60 mg. 60.
Sorry, 60.
10
Sorry,
milligram per hourly means it is 6
60
times per
60.
day.
Sorry.
Yeah. So it is 60 mg. So 60 mg per day. So what is the duration of action of controlled release tablet or sustained release tablet? It is 12 hours. Okay. So duration of action is 12 hours. So how do you give sustained release morphine for this patient? What should be the dose?
30 mg twice a day.
Yeah, 30 mg BD, isn't it? It should be 30 mg BD. But this patient also can have pain in between. So what would you do?
We can give SOS tablet along with it. If he has pain, he can take 10 mg of morphine oral tablet SOS.
Yeah, that's what it is important. You have to give 10 mg of immediate release morphine, not 10 mg of sustained release morphine or 30 mg of sustained release morphine. It is 10 milligram of immediate release morphine. That is which acts for 4 hours. Okay. So these are the preparations of morphine available. We have aqueous solution, that is syrup. And then tablets as well as capsules are available, which is available in both immediate release as well as controlled release form. Then injection is available. In Kerala, it is 1 ampule contains 15 milligram in 1 ml. But this would be different for different countries and also for different states. So our patient story, we are continuing. Mr. X now is on 10 milligram of morphine 4 hourly for the past 6 months. And then he was brought to you with excessive drowsiness, and you are the person on casualty duty, and you do some investigation and find out that TC is elevated 13,000, blood urea is 20 milligrams per deciliter, serum creatinine is 5 milligrams per deciliter. Would you do anything with morphine dosage? Anybody?
We will decrease the dose.
Okay. Why should we decrease the dose?
He's been drowsy, and drowsiness is one of the side effects of morphine. Also, his creatinine level is high, so the excretion of the metabolites of morphine might be hampering this. So if we decrease the dose, then maybe the patient may get back to his consciousness.
Okay, thank you, Professor. What we have to understand is morphine is excreted from the body by glomerular filtration. So this patient has a serum creatinine of 5.5 milligrams per deciliter. That means the creatinine is at a higher level. So whatever you are giving to the patient, it is not eliminated from the body. It is getting accumulated in the body, and that can produce many problems, including drowsiness, sometimes lead to convulsions. Morphine and its metabolites are excreted from the body by renal route. So whenever the patient has impaired renal metabolism, then you have to reduce the dose of the morphine. So you have to actually reduce the dose as well as increase the space. So instead of 4 hourly, you make it 8 hourly, 6 hourly, or 12 hourly, or even once daily. Okay. And or otherwise, you can give opioids which are supposed to be renally safe. So which are renally safe opioids? Fentanyl and methadone are the two opioids which is comparatively safer, even if the patient has renal impairment. So after this problem, you reduce the dose of morphine to 5 milligram, and now he is taking 5 milligram 8 hours a day. But his general condition is gradually deteriorating, and he is unable to swallow anything after 2 months, including morphine. And the patient is at home, probably because the patient is deteriorating and maybe at the end of life. So what will you do now for pain relief for this patient?
We can give subcutaneous morphine.
Okay, yeah, subcutaneous morphine. But is it possible to give morphine subcutaneously, or would your hospital allow the patient to give subcutaneous morphine to patient at home?
We can
Injectable
give
morphine?
IV. We can give IV. We can start an IV.
Yeah, injectable morphine, that's an option. But the patient should be at hospital, isn't it? This patient is at home. Yeah.
Patches are available, transdermal patches.
Patches, morphine patches are not available.
Maybe we can change to transdermal fentanyl.
Which one?
Maybe we can change to transdermal fentanyl.
Transdermal
Fentanyl
fentanyl.
patch.
No, fentanyl.
Fentanyl patch.
Okay. Yeah. But let's see what are the routes through which we can give morphine. So the most common route is oral, isn't it? Then followed by subcutaneous or intravenous route. Morphine can also be given parectally. Okay. Then epidural, intrathecal. So this patient is at home. So we can give morphine parectally in this patient. If the patient is at hospital, then maybe intravenous or subcutaneous can be tried. So this patient, parectal morphine can be given. So whatever you are administering orally, that can be given parectally. So this patient is taking 5 milligram 8 hourly. So you can administer the same dose parectally. Okay. And the efficacy, pain relief, all are comparable to oral route. So this patient will receive 5 milligram parectal 8 hourly, the fast acting tablet. So I already told you that it is water soluble. So take 5 milligram of morphine tablet, add 2 drops of water, make it a paste, and just do a parectal examination and deposit this paste in the rectal mucosa. Okay, we are moving on to another patient. Mrs. K, 55-year-old lady with carcinoma of the colon, has abdominal pain, which is continuous in nature, and she is on 10 milligram of morphine 4 hourly. But with the present morphine dose, she has good pain relief. As the patient does not want to take it every 4 hourly, the doctor has asked them to replace the morphine with a 25 microgram transdermal fentanyl patch. The very next day, patient comes to you and tell you that she replaced the fentanyl patch after 5 hours, as she had no pain relief with fentanyl patch. Now, what are you going to do for this patient?
We have to give a rest.
Sorry, Priyanka, you are audible.
And then start oral morphine.
Oral morphine. Okay, thank you. I can see Anjali has raised her
Am I audible?
Yeah. Anjali.
Fentanyl patch takes time for work, at least 24 hours. So
48 hours, it takes time. So during that time, you have to give a adequate pain relief till the fentanyl works.
Okay. Thank you.
Hello,
Anjali.
am I audible?
Yeah. Okay. So just see the fentanyl patch. So you can see this is the fentanyl patch, and it has a, protective layer on the outermost aspect, which we need to peel it off before applying. And then there is a adhesive part. Okay. And above that there is a release membrane. And you can see this is the drug reservoir. And when you apply the patch, the drug will slowly deposited into the subcutaneous tissue, and it will form a subcutaneous tissue depot. Okay, so this is where the storage of fentanyl happens, and from this subcutaneous tissue depot, fentanyl will be liberated into the systemic circulation. Suppose you have applied 25 microgram fentanyl patch, that means 25 microgram of fentanyl will be liberated every hourly to the systemic circulation. But for this subcutaneous tissue depot to occur, it will take about 8 to 12 hours. Okay, so till then, the patient will not have pain relief. So actually, this patient need to continue the morphine which she was using previously, but she was not advised to take morphine till that time. So that's why this patient didn't have pain relief. So these are some points which we need to actually uh, inform the patient. Otherwise, they will do such things. So these are things which has actually patients. This patient came to us by another oncologist who has applied the patch, and this patient came to us and told us that there is no pain relief, so that's why they removed the patch. So understand, it will take about 8 to 12 hours for pain relief to occur. And till that time, you have to continue the previous opioid which the patient was taking. And the duration of action of fentanyl patch is 72 hours. So for after 3 days, you have to remove the remove it, and you have to apply a new patch. And every time when you apply, please change the position where you apply the patch. And another thing is that you should not shave the area. Should not, because it will produce more aberrations in the skin, and that is going to actually increase the absorption of fentanyl. And also temperature is also will also affect the absorption. So if the patient has fever, or if the patient is going to take a hot bath, that all going to increase the absorption. So these are few things which you need to actually educate the patient. So now you know that when you apply a fentanyl patch, that will liberate only constant amount of fentanyl into the systemic circulation. So it is not suitable for patients whose pain is constantly or whose pain is not stabilized. That means this patient's pain sometimes come down very fast, and after some time it goes up, then come down. So that means it is the pain is not stabilized. So in such patients, fentanyl patch is not a suitable option. And if the patient has breakthrough pain, you can this patient who was on 10 milligram of morphine per hourly, you have to give 10 milligram as SOS dose when you apply the fentanyl patch. So these are the preparations available. Injections are available. Transdermal fentanyl patch, oral transmucosal fentanyl citrate, which was available previously. It is like a lollipop. You have to rub over the buccal mucosa, and it will give instantaneous pain relief. So this is helpful for those patients who has pain during movement. Suppose the patient has pain only during walking and they want to go to bathroom. So at that time, they can just rub over the buccal mucosa, and that will give good pain relief. And another important thing is fentanyl is more potent than morphine. It is 100 times more potent than morphine. And if you calculate with 100 times as potency, then 60 milligram of oral morphine would be equivalent to 25 microgram per hour patch. So 120 milligram of oral morphine equivalent per day would be equal to 50 microgram per hour fentanyl patch. So we have another lady, 70-year-old man with carcinoma of the lung and is complaining of throbbing pain on front of chest. Continuous 5/10. He is a non-epileptic and is on levetiracetam 500 milligram BD. How do you manage this pain? Anybody? Anybody? So what is the pain score here? It is 5/10.
Visceral pain.
Okay. Okay. Visceral nociceptive pain. Okay. Yeah.
We can add NSAID. NSAID we'll give.
Okay. But as per WHO analgesic ladder, which step of WHO analgesic ladder should you use in this patient?
That is the first step.
So first step is for what type of pain? Is it for mild pain or moderate pain or
mild nociceptive?
No.
So this is not nociceptive. So we give tramadol. We can add.
So WHO analgesic ladder, it is according to the severity of the pain. It is not according to the type of pain. So mild pain, first step. Moderate pain, second step. So 0 to 1 to 3, you can say it is mild pain. Then 4 to 6, it is moderate pain. Then 7 and beyond, it is severe pain. So here it is 5/10. So you have to select second step, isn't it? So what would you give in this patient? In the second step of WHO analgesic ladder, it is opioids for mild to moderate pain, plus or minus non-opioid, plus or minus adjunct. Yeah.
We'll add tramadol.
Okay.
With opioid.
Sorry. It's
Tramadol can have effect on his epilepsy. So I think we should avoid tramadol and start with morphine injection and titrate the dose to see how his pain relief is going, and then start with oral morphine tablets.
Yeah, thank you. I cannot see who is speaking, but
it was
that's
Harsha.
right.
It was Harsha.
Yeah, Harsha. So what you have to understand this patient is epileptic. So tramadol has some problem with epilepsy. It can actually reduce the seizure threshold. So it can precipitate a seizure, especially in patients who are non-epileptic or patients who have brain metastasis or patients who are taking other medication that can reduce the seizure threshold. So this patient is already epileptic. So it is better not to start on tramadol. But I have not seen any patient who developed seizure with tramadol. Theoretically, it is yes. So even if you are giving tramadol, give it, especially with injectable tramadol, give it very slowly. Okay. So, but ideally, this patient should not be on tramadol. Maybe a low dose of morphine can be used here. Okay. So there is this is another patient.
Please, can we use tapentadol to this
Tapentadol,
patient?
yeah, but tapentadol also has the same problem as that of tramadol. So better to avoid tapentadol also. Tapentadol is the newer derivative of tramadol. Okay.
Should we use the buprenorphine sublingual tablets?
Buprenorphine, in chronic pain management, buprenorphine does not have a role if we have
On
morphine.
SOS basis?
And no, this patient has continuous pain, so it should not be used. You can see right front of chest, it is continuous. So there is, if the patient has continuous pain, that means you have to use analgesic down the floor. So buprenorphine is not very favored medication because of its partial agonistic property. We are coming on to that. So this patient, another patient, Mrs. P on tab morphine 50 milligram 4 hourly. She attends your clinic with severe pain. You have injection pentazocine and oral morphine tablet. How are you going to manage? Okay. So for getting that answer, we need to know a little bit of pharmacology of opioids. So opioids act on opioid receptors, and there are mainly mu, kappa, and delta. These are the opioid receptors. Okay, and on combining with this opioid receptors, the opioids will give you the pain relief as well as it will produce the side effects. Okay, and its action is antagonized by naloxone. If the medicine is an opioid, its action can be antagonized by naloxone or it is reversed by naloxone. And this is the classification of opioids depending on the interaction at the receptor side. It is divided into agonist, antagonist, and agonist antagonist. Agonist means these are opioids which acts on opioid receptors and will produce physiological action, that is pain relief and other side effects. Agonist antagonist means on certain receptors that opioid will act as an agonist, but on other receptors it will act as antagonist. So it is agonist antagonist. And antagonist means it is a medication that can be used to reverse the effect of an agonist. Okay, so antagonists work only in presence of an opioid agonist. Suppose if I give you naloxone, it is an antagonist. It is not going to work in your body. It will not have any action in your body because you are not taking any opioids. Okay. So this is something which you need to understand. This is the main difference between agonist and antagonist. In the first graph, you can see an agonist opioid. Most of the opioids which we know are agonist: morphine, fentanyl, methadone, tramadol, all are agonist opioids. So suppose this patient has severe pain, till here, and this is the dose of agonist you are going to give. Suppose you have given 5 milligram of morphine, the first line, and that will give some pain relief. But as you increase the dose of morphine, that will give corresponding pain relief. And theoretically, when you reach here, till this dose, okay, you will get complete pain relief. That means this group of opioids does not have ceiling effect for analgesia. Okay, so this word ceiling effect. So agonist opioids does not have ceiling effect for analgesia, whereas agonist antagonist, you can see when you increase the dose, it will give you corresponding pain relief up to a point. You can see until this point, if you increase the dose of agonist antagonist, it will give corresponding pain relief. But after this point, even if you increase the dose, it will not give corresponding pain relief. That means it has ceiling effect for analgesia. Okay, so that's the main difference. Agonist antagonist has ceiling effect for analgesia. And examples of agonist antagonists are pentazocine, that is the protein which we use commonly, and the buprenorphine, that is again coming in agonist antagonist. So our patient who was on 50 milligram of morphine, suppose if we give him pentazocine, what is going to happen? Pentazocine has two effects. it has an agonistic effect at kappa receptor, but has a weak antagonistic effect at mu. But whereas morphine is a mu agonist. So when you give pentazocine to a patient who is on morphine, what will happen? Morphine will be displaced from the mu receptor and pentazocine will occupy the mu receptor then. So the pain relief would be due to then only due to kappa receptor, the action of pentazocine on kappa receptor. But opioids which are acting on mu receptors are the potent opioids, fentanyl, methadone, morphine. Those are potent opioids because they act on mu receptor. But here what happened? Pentazocine has displaced morphine from the mu. And now pentazocine is acting as an antagonist. Okay. So what will happen if you give pentazocine to this patient? Actually, it can increase the pain. Okay. So it is better to give tab morphine itself. So if a patient is on large dose of mu agonist, don't administer any partial or agonist antagonist opioids to that patient. Okay, now we are moving on to adverse effects. So adverse effects of opioids can be divided into two: side effects and toxic effects. What are side effects? Side effects means these are adverse effects with therapeutic dose. So what are those? Constipation, nausea, vomiting, sleepiness and tiredness, itching, dry mouth, urinary hesitancy. So these are the first three are the common side effects, and the last three are not very common. You can say rare side effects. And out of this, constipation is the most common side effect, which occurs in almost 95% of the patient. And the peculiarity is that constipation will be there as long as the patient is on opioids. So you have to prescribe a laxative along with an opioid whenever you prescribe. And it is not a laxative, it is specifically stimulant laxatives are used to treat opioid-induced constipation. So examples are bisacodyl, sodium picosulfate, and senna. And nausea and vomiting. It occurs in almost 30% of patients, but this will be there only for the first 3 to 5 days. So it is self-limiting. That's what you have to understand. Constipation, there is, it will continue, but nausea and vomiting will be there only for the first 3 to 5 days. And it is due to stimulation of chemoreceptor trigger zone in the brain. So maybe for the first 3 to 5 days, you have to give an antiemetic which acts on CT cell. So these are haloperidol, metoclopramide, or domperidone. This is the preferred choice of antiemetic in opioid-induced nausea and vomiting. Next side effect, sleepiness and tiredness. But this is again self-limiting. You need not actually do anything for the patients because it is expected to have little bit of drowsiness on the first 3 to 5 days or maximum of a week. Then next adverse effect, we divide into side effects and toxic effect. The toxic effect means whenever you give more than required dose of opioid, that can produce some adverse effects which are known as toxic effects. So what are toxic effects, or how do you know this is toxic effect? It will manifest as delirium, myoclonic jerks, or extreme drowsiness. Okay, delirium, myoclonus, or extreme drowsiness, pinpoint people. And if it is there, then you have to reduce the dose of the opioid that you are giving. So this is what all of you have told in the first, when we began, opioids producing respiratory depression. How common it is? Whenever we look at pharmacology textbook, this is project as the main side effect. But how common it is? So this is a systematic review from 2003, and you can see mainly the patients takes their medications, that is opioids, by mouth. So you know that if you give by mouth, the opioids will be gradually absorbed into the blood, and the blood level will only gradually rise. It is not like giving an IV push. So this is combined with the normal gradual increase in dose ensures that respiratory depression is unusual. I have not seen any patient with respiratory depression during the last 20 years of my career in palliative care. I have prescribed oral morphine, methadone, injection fentanyl, injection morphine for thousands of patients, but I have not seen any case of respiratory depression. And this continues to say that when a patient has respiratory compromise, you should look at whether the patient has pneumonia, do they have pulmonary embolism, or is there any cardiomyopathy, or are you administering another sedating medication like benzodiazepine? So these are the risk factors. Okay. So another thing which would be in your mind will be addiction. Okay. So it says substance abuse as a result of medical use is low. And there is a confusion between physical dependence and psychological dependence. Psychological dependence is known as addiction. But in psychiatry, they use another word known as substance use disorder, that is SUD. But for us to understand, it is better to use the term physical dependence and psychological dependence. So I will give you an example. Many of you will be taking coffee in the morning for the last so many years. And suppose you do not get coffee in the morning. And what usually happens to you? What will happen?
We get headache and we become irritable.
Yeah, headache, irritation.
Yeah.
Yeah. So is it addiction?
Sort of.
Sort of. Yeah. So how many of you are taking coffee? I do not take coffee.
I take.
Okay. Yeah. But what you have to understand is that is physical dependence. You did not get coffee because there were no coffee powder and sugar in your home during that day. But you know that in the neighbor's house, coffee powder and sugar is kept, but they have locked the house and they have gone out. And you know that. And if you are breaking into that neighbor's house and taking coffee powder and sugar, then that means you have addiction. That is the psychological dependence. But we can adjust even if we do not get coffee for one day, isn't it? We might be some irritable or having headache, things like that. But that is we usually do not break into neighbor's house for getting coffee powder and sugar. So that's the difference between addiction or psychological dependence and physical dependence. So you have been giving coffee to your body for the past 25 years, and one day morning you are not giving. So your body is asking you, why are you not giving me coffee? Please give. So that is manifested as withdrawal reaction. Withdrawal reaction. There are many symptoms that can occur depending on the drugs or medications that you are taking. Okay, so let's see what is addiction. This is what the definition, and they say it is a primary chronic neurobiologic disease. Okay, so American Pain Society define it as a disease with genetic predisposition. Okay, and your psychosocial and environmental factors are going to influence its development and manifestation. So that means, suppose one of you have a gene for addiction, and you are working in a theater, operation theater, where lots of opioids are available, and one of your friend is misusing this opioids, and she's telling you that, Dr. Pramalada, uh, this is a very good medication. You try it. I am using it. It is so much comfortable for me, and that means you have a gene. Your psychosocial and environment is favorable. So there is a chance that you may also um, misuse the opioid. Okay, and you know that you will do anything to get that medication, and you also know that this is not taken for its physiological effect or for pain relief. It is taken for something else that you know, and you know that it is going to cause harm to you. And for typically, these patients will come to you and will tell you that my opioid medications are over. You have prescribed it for 2 weeks, but after 2 days or 3 days, they are coming and tell you that, madam, I lost those morphine tablets. It was heavily raining, and that was destroyed. And they may also come and tell you during the travel, I lost it in the bus. And they may escalate the dose without your sanction. It will be from 5 milligram to 10 milligram, next day to 15, 20. That will be the type of escalation that they are going to use. So these are some manifestations, or these are some symptoms or behaviors by which you can understand that the patient might have psychological dependence. Okay, so I am moving on to please find the cost of opioid medications also. So a patient who is on 5 milligram of morphine for hourly, so the total dose would be 30 milligram, and so 3 10 milligram tablets, that will cost about 3 rupees 50 paisa. But to get the same pain relief, you have to take 300 milligram of tramadol, and the patient need to spend about 24 to 50 rupees per day. Whereas fentanyl patch, you have to use 12.5 microgram, which would be around 100 rupees per day. Whereas buprenorphine patch, it will be again more costly. And if you take methadone, that would be comparable with morphine. So for a patient, if you are going to prescribe buprenorphine patch or fentanyl patch, please remember, patient may not use it. And even if they are going to use it, they may not be able to continue with fentanyl patch or buprenorphine patch unless they are Tata or Birla or somebody like that. Okay, so I think I will stop here. And we'll move on to case presentation, or if you have any questions, you can ask.
Sir, which is the best antiemetic, metoclopramide or ondansetron for morphine induced vomiting? Hello?
Yeah. So if you look at the evidence, previously, I think Oxford Textbook of Palliative Medicine, 3rd edition, which said that drug of choice for opioid-induced nausea and vomiting is haloperidol. Okay. So, but now if you look at the latest edition of Oxford, It does not talk about the drug of choice, but those who are or there is palliative care formulary which we usually use or refer for medications in palliative care, which says the drugs which block dopaminergic type 2 receptors in the CT cell are the first choice of medication to treat nausea and vomiting due to opioids. So, which is the strongest D2 blocker? It is haloperidol. Then comes metoclopramide, then comes domperidone. But haloperidol can, many people may not use haloperidol. We usually use metoclopramide as our first drug of choice for opioid-induced nausea and vomiting. It has its own advantage compared to haloperidol. And ondansetron 5-HT3 blockers, we use it as a third line. The first line is D2 blockers. Yes.
You told about the fentanyl patch. It starts acting at around 8 hours and it should be replaced every 72 hours, right? It works
Yes,
for
yes.
72 hours.
Yes,
So when
yes.
we are replacing the patch, we should put exactly at 72 hours or giving a time frame, we should put it around like 65 to 70 hours like that. What time is exactly the patch replacement?
No, it should be every 72 hours.
Okay.
Dr. Vishnupriya, you are correct in a way that domperidone does not have much central action. It has mainly peripheral action. The dopaminergic type 2 receptors in the DIT. But ondansetron is not a favored drug over haloperidol or metoclopramide. Maybe you can use the other antipsychotics as second line medications. No, constipation should be treated with and there is a question again by Vishnupriya. Constipation due to tramadol can be treated with domperidone or only with disapodate. So, domperidone or metoclopramide, these are prokinetic medications that has antiemetic property. So, prokinetic means it increases the bowel movement. Okay, but it also has an action on vomiting. It reduces the nausea and vomiting. So if you look at the mechanism of action of opioids, which produces constipation, it is by reducing the bowel movements, and also it will increase the reabsorption of fluids from the intestine. It will increase the sphincter tone of anus, and it will also reduce the sensation. We defecate when we have the sensation, and that the sensation will come when there is the rectum is loaded with fecal matter. But this sensation will be reduced by opioids. So these are the mechanism by which opioids produces constipation. Laxative, stimulant laxative means it is laxative, along with it will increase the movement of or peristalsis in the large bowel. So laxatives should be used as the to treat constipation, and not the not the prokinetic or antiemetic. Yeah, already I already talked about cost of fentanyl patch. 12.5 microgram costs about 250 to 400 rupees depending on the place. So it is a costly affair. Dose adjustment chart for morphine. I didn't understand in which what condition are you talking about? how will dose to laxative? Okay, laxative usually started with 2 Hs, bisacodyl 5 milligram 2 Hs, and then you can titrate it up to 10 milligram TID, and maybe you might also add an osmotic laxative like lactulose along with stimulant laxative. IV morphine titration in patients. How to titrate it is the same as what we have described. If we give opioid with any centrally acting muscle relaxant, will it increase the drowsiness? Yeah, theoretically there is a chance. But so you may want to not start the patient on full dose of muscle relaxant. May start with a lesser dose of muscle relaxant and gradually increase. Preferred site for fentanyl patch. The fentanyl is absorbed into the subcutaneous tissue. So wherever there is more subcutaneous tissue, it would be a better site. But there is no preferred site. But many patients apply it over areas where there is no hair, like in the mastoid process here behind the ear, so that you need not shave the area, just apply it. Otherwise, in most of the body parts, there will be hair. So whenever you apply the patch, there is a tendency to it will keep slip off from that area. Any dose adjustment chart according to there is no dose adjustment according to creatinine clearance, but what I can tell you is up to CKD stage 3, you can use the normal amount of morphine that you are going to use, but then from 4th onwards you have to reduce. Maybe 4th stage, CKD stage 4, you have to reduce 25%, and CKD stage 5, you have to reduce 50 to 75%. What are the contraindications of tramadol? Can we use it in hypertension, diabetes mellitus, cardiac problems, liver problems, kidney problems, epilepsy patients? The main thing which we already told is it can reduce the seizure threshold. Tramadol can reduce the seizure threshold. So if possible, you have to avoid tramadol in patients who has a tendency to have seizures, like epileptic patients or patients with brain metastasis, or patients who are taking other medications which produces or which decreases the seizure threshold, like tricyclic antidepressants. And you should not go beyond the maximum dose of tramadol. The maximum recommended dose is 400 milligram per day. But otherwise, there is no contraindication. And if the patient having severe liver disease, then you have to reduce the dose of opioids that you are giving. If we give sedative drug with opioid, will it increase drowsiness to patients? It can increase the drowsiness, but we are more worried about respiratory depression if it is not given appropriately. You can actually, if you give the regular or normal dose, like 1 milligram, midazolam 1 milligram, clonazepam 0.25 milligram, it is not going to cause much problem for the patient. But if you give large amount of benzodiazepine, like maybe continuous infusion of benzodiazepine along with continuous infusion of opioid, then you should actually monitor the patient. Okay. I think we can have the case presentation quickly. Sripriya?
Yes, sir. Dr. Niranjan?
Hello, can you hear me?
Yes, please tell me.
Okay. Good evening, everyone. Next slide, please, madam. I'm going to discuss about a patient who is a 72-year-old male who has diagnosed to have metastatic prostate cancer with DVT and extensive bone metastasis. So he presented to our OPD for generalized bone pain for 3 months, which increased over the last 2 weeks, and bilateral leg swelling with pain in the lower limbs for the last 1 week. Just to brief history, he was a 72-year-old man diagnosed to have a localized prostate cancer, underwent robotic prostatectomy in June 2020. Subsequently, 2 years down the line with routine treatment, was found to have a metastatic disease 2 years later with extensive liver bone metastasis in both axial and appendicular skeleton. Unfortunately, the traditional adenocarcinoma changed to a small cell type. So there was a rapid progression. He received 6 cycles of chemo along with bone strengthening bisphosphonates, had a progressive disease. The repeat biopsy was suggestive of a RET mutated cancer. Then he was started on a RET inhibitor from July 2022. So the disease progressed on the RET inhibitor. 6 months later, he had developed generalized bone pain. It's dull aching in nature. Initially was managed with ultraset 3 times a day. As the pain was not settling down with ultraset over the last 2 weeks, sudden onset increased. It was even present at rest, and sleep was disturbed at night because of the pain. He came to us for further evaluation from a different hospital. There was a bilateral leg swelling associated with pain for the last 1 week. There was no breathlessness, reduced urine output, or fever. On examination, there was a bilateral lower limb edema. It was there up to mid-thigh, warmth, lessened, tenderness present. There were inguinal nodes bilaterally. Scrotal edema was also present. There was tenderness present over the lumbar spine region. There was an ontology gait when he was sent to our OPD clinic. Per abdomen, we could find there was nodules over the port side deposits also. So the routine investigation suggested a hypercalcemia, and creatinine clearance was slightly higher. So the bilateral compression ultrasound and Doppler was suggestive of DVT, both legs, femoral popliteal veins, all throughout. PET-CT was suggestive of a progressive disease with extensive skeletal metastasis involving the vertebra, ribs, femur, humerus, scapula, port side deposits, bilateral HUN causing the pelvic deposits, the nodes, everything. There was thrombus involving the external iliac and femoral veins. So the psychosocial aspects in this case was he knows the disease. So initially the prostate cancer, as everyone told him, it was very good, you tend to live for a long time. Unfortunately, he had a small cell variant which was progressive, and he knew that he's not going to live long. So there was a concern about his life expectancy and how he's going to cope up with that. Second thing is he comes from down south to a native town. He's like almost like the leader or important person. So he used to have frequent visits. He runs an industry and he was the head of the person in that town. So because of this pain, he's like almost bedridden, and his huge lower limb DVT and edema, he's unable to move. His mobility is restricted. So he's almost like bed bound. Not completely, he can able to, but most of the time he spends in his bed. And because of the pain, he's unable to control. The pain tolerance has reduced, and the character, everything has changed. His mood is low, his appetite is low. Whenever he's asked to eat, he feels, please leave me alone. That was his only reply whenever he was asked. And the family temple renovation was going on in his native place. It was due in April 2024, and he wishes to walk without any pain, or the edema should settle down to attend the temple function. So those are the psychosocial aspects. So in view of elevated creatinine, we were able to start him on denosumab for reducing the hypercalcemia as well as the metastatic bone disease. For the DVT, we started him initially on a rivaroxaban, and we started on low dose morphine, intermediate release, started at 5 mg. And with the pain related, it was not settling down. He required 2-3 SOS medication. Finally, we titrated it to 15 mg in 4 days time. And the adjuvant para, he was started on 1 gram TTS. We gave him perinom and syrup cremacin plus 15 ml twice a day. He was planned for, this was the medication part. For the treatment related point of view, he was planned for second line treatment option, which was because of small cell change. So the main concern for him is the pain. So we were trying to increase the dose, but despite on 15 mg, the pain related to the DVT part was unable to get controlled, first thing. And the edema was restricting his movement, so which he doesn't like. He used to be the most active person in his town, but he's unable to move right now. And because the retin inhibitors were really costly, and he was actually had to, he doesn't want to leave the family in burden by continuing further treatment, but the family wishes to have treatment. So there was a frequent conflicts between the family and the person for regarding what next to do financially. And from the cancer point of view, there was, for small cell variant, there was not much options left, and which he couldn't take it in the right way. But he was concerned, can he do something else? So then the immunotherapy part came and the cost issues came. So he was a bit concerned about everything. And the temple function he needs to attend. Unfortunately, the pedal edema did not settle down with the treatment. We were initially planning for a localized radiotherapy to the inguinal nodes, but we were scared whether giving radiation will worsen the edema again. So we were waiting for the river of the band to act. We started developing skin blisters over the edematic region. And severe constipation initially after starting morphine, requiring enema and rectal evacuation of stools. Initially, we were giving only cremacin plus 15 ml twice a day. Later on, we were able to give him a tablet called Q-Senosoft at night. So post enema, we were able to manage that constipation part as well. To summarize, a 72-year-old and one more thing, previous slide, please. Previous slide. The happy rate has significantly reduced because of this condition, and we couldn't give DEXA to improve the appetite because he was on immunotherapy. We can't give metroxyprogesterone acetate because he already has a DVT. So regarding appetite stimulant, we were wondering what else we could do to help him out. Next slide, please, madam. So to summarize, this 70-year-old gentleman with metastatic prostate cancer with DVT and extensive bone metastasis. Pain not controlled with ultrasound, we escalated to morphine, developed severe constipation requiring enema. He has a DVT and a lower limb edema, limiting his activity and making him bedbound. The pedal edema was not settling down with conservative management. His last wish was to attend the temple function before the disease takes a toll on him. Points to ponder: any other means of reducing the pedal edema? How fast can we switch to a fentanyl patch because of creatine clearance? We don't want him to end up having the toxicity related to morphine. Any role of radioisotopes in pain management because of extensive bone metastasis like a summarium or a lutetium? Appetite stimulant, can't use DEXA or metroxyprogesterone acetate. And opioid-associated constipation and the role of antidepressants here. Will it worsen the constipation in addition to what we are supposed to? These are things we would like to discuss with you.
Thank you, Dr. Niranjan. That was an excellent patient story. And if anybody want to comment on this, please.
For reducing the edema, we tried the traditional Epsom salt, sir, because we couldn't reduce the edema through the veins, and because the DVT is there, the lymphatics is blocked because of the nodes. So what we did was we tried this Epsom salt, Maxel, traditionally, or what we use for orthopedic dressing. So we tried, but it did help him to some extent, but no, sir, it was the effective was actually a futile. More than 10 days, he couldn't do anything.
Okay. Anybody else has any idea?
Sir, I want to add regarding the role of radioisotopes in pain management, because we do give radioisotopes like samarium 153 and lutetium 177 EDTMP we give for metastatic bone pain we give. And actually, after giving this radioisotopes, either samarium 153 or lutetium 177 EDTMP, the pain, after giving isotope, the pain may start anywhere between 1 week to 6 weeks. So after giving isotopes, we have to follow up the patient, and gradually we can step down the morphine dose. Gradually, we have to step down the morphine dose. So that one we can try actually. So sometimes after giving these isotopes for bone pain palliation, we can reduce the morphine doses, we can step down also. So that one possibility is there.
Okay. Thank you. Sir, how frequent will you administer, sir? Because he was planned for chemo also. The bone marrow suppression will also be a side effect of radioisotopes. Just wanted to add to that point.
Dr. Dhanapati?
Sorry, hemoglobin has to be above 10, and even WBC count has to be 2,500 above, and platelet at least it has to be above 1 lakh. So these are, if all these marrow parameters are good, we can give actually. But sometimes if patient has already received chemotherapy and all, if his marrow is suppressed, means actually we can reduce the dose. Half dose also we can reduce the dose and we can give also.
So what is the cost involved?
Cost actually we can get it from BRC, Brit from Bombay we can get it actually. So it is around somewhere between I think around 15,000 it is there, one dose. But this will last for at least 3 months, like that the pain relief will start actually. But we have to continue, as I said, we have to continue with the other palliation drugs also. We have to continue, and we have to slowly step down the other doses. After we have to evaluate the patient, and if his pain is controlled, then gradually we have to step down the morphine doses.
Okay. So that's for extensive bone metastasis.
Yes.
Yeah. So there was a question regarding edema, and maybe I think we can use some compression bandaging. And I just want to point out that this patient do not want to go with second-line chemotherapy and things like that.
Yes, sir.
Yeah. So in such patients, they have already decided that okay, I would like only. I do not want to have further treatment. Maybe is it because of the poor psychosocial status, or he knew that this will not respond to any oncological interventions?
Nice question, sir. The thing is, he's, despite coming from a rural background, he's a bit educated and he's an industrialist. So he himself has searched the internet and he came to know the average life expectancy of a small cell carcinoma of prostate. The only thing is, he knew that he is going to die in few months or so. But thing is, this DVT and the rapid disease progression needs to be addressed because he has a temple issue which was pending. He presented to us in January, and he needed at least 3 months to be better so that he can head the function at this native temple. He was desperate for something, but at the same time, what he was telling to us was, I have already spent enough. I don't want to put any extra toll on the family because we need to sell few properties for me to get such treatments. So he is in a denial, but at the same time, he was helpless. So that's when we were thinking of any other source of antidepressants or anything that we could do to elevate his mood at least.
Yeah. Um, so if the patient and the treating team decides, okay, this patient does not have a good prognosis and any other second line chemo would not do much benefit for the patient, then we should concentrate on comfort care.
Okay, sir.
And then what I want to tell you is we would do all the things which makes him comfortable, but the comfort sometimes would be at the cost of some risk also. So that patient and we have to accept. By making comfortable, by giving some medication, it can have some side effects also that the patient has to accept. And we also have to understand that now the goals of care is comfort care. That's one thing we have to keep it in our mind. And maybe if that is in our mind, then maybe some compression bandaging might help to reduce the edema.
Okay, sir.
I do not have any other idea in my mind regarding reducing the edema of the patient. Compression bandage is one option. Then maybe even actually you can change the patient onto fentanyl if you want, but I might go on increasing the morphine dose if there is no toxicities like drowsiness, myoclonus, or delirium for the patient.
Okay, sir.
So these are the signs which says us that okay, this is the end point, or this is the point till which you can increase the dose of opioid, or that particular opioid. But if you switch from one opioid to another opioid, the side effect may wear off. So you may convert the patient from morphine to fentanyl if the patient has toxicities. That's also that should be okay. But also consider the cost of medication. And regarding the use of antidepressants, I would use antidepressants only if I feel that okay, this patient, in this patient there are two possibilities. One is this patient might have some neuropathic pain, and I may give that chance and may start him on a tricyclic antidepressant like amitriptyline, which will also help to elevate the mood.
Okay, sir.
And what were your other questions? I don't remember.
This, sir, morphine associated constipation.
Yeah.
One we have already dealt with.
Yeah, but and this is a problem which some patients might have. So give Dulcolax, then add with osmotic laxative like lactulose. And if this does not work, then you can use polyethylene glycol. Polyethylene glycol sachet is available, but it is also available as powder form. So you can use to start with 2 teaspoons, 1 teaspoon BD in 100 ml of water. And most of the patients will have good bowel movement with polyethylene glycol. And if all the conventional methods fails, then maybe you have to use teach the caregiver to how to do character examination and if needed digital evacuation with enema also. And there is something called methyl naltrexone, which is used in opioid resistant constipation. But it is not available in India. It is available in other countries like UK, US, etc. We do not have that.
Okay, sir.
So Priya, I am afraid that we have to stop the session now because I have to go for another session at 7 o'clock. So thank you, Dr. Niranjan, for that excellent patient story. And there were a lot of points that we actually you wanted to discuss, but I don't know whether you are satisfied. If you have any doubts, you can send the questions to us so that we can answer.
Definitely. Thank you, sir. Thank you.
So Priya, it's over to you.
Thank you, sir. Thank you so much. I do completely understand your busy schedule as I am also associated with you. Thank you so much. Still, you found out time and you spent extra 20 minutes for this cover. Thank you so much for that. And thank you everyone for joining in. And we believe that maybe some of your queries might not. I think last query we got in the chat box, which is yet to be addressed. With a promise that all those will be taken care of once you post it in the online queries data bank which we have shared. This is Sripriya along with Dr. Sunil Kumar and Mr. Anup signing off from the Tips Eco Hub. See you in the next session with the continuation of management of pain. Till then, everyone, take care. Bye bye.